Okay, this is the first of Dr. Cross's Cell Pathology and Infection lectures, and this is just to give you initially an overview of my sessions. So today, in this session, we're going to look at some basic pathological terminology, and once we've covered that, we're going to move into some histopathology, cytology, with a particular emphasis on malignant disease. So throughout these sessions, we're going to be looking at the cellular and genetic changes in cancer, so we'll be covering lots of tumour suppressor genes, lots of oncogenes. We'll also be covering the role of infectious agents in cancer, so focusing on human papillomavirus and looking at how human papillomavirus can disrupt key tumour suppressor genes to induce cancer formation. We'll also be focusing on the molecular testing that takes place, so histopathology is looking at tissues down the microscope. We'll also be looking at molecular testing, so doing genetic tests like fluorescence, in situ hybridization, polymerase chain reaction and sequencing, and seeing how these molecular tests can also help to predict patient outcomes. So we'll be looking at HPV genotypes, looking at genetic changes in cancer cells to see if they will predict disease progression, or specifically whether they predict sensitivity to anti-tumor agents, and we'll focus on Herceptin and cetuximab in this area. In addition, we'll look at other molecular tests such as the Oncotype DX assay, which you covered briefly in biomedical investigations last year or the year before, but we'll be looking at assays such as Oncotype DX that can predict chemotherapy responses. So the whole module is an overview of basic pathological terminology, understanding histopathology, understanding cytology, but we're also going to be looking at the genetic basis of cancer, how cancer forms, how tumour suppressor genes and oncogenes work together to limit normal cell growth, and how that goes wrong in cancer. We'll then also be looking at key mutations in cancer cells, such as mutations to RAS, which is an oncogene, and how that negatively affects responses to specific therapies. So that's sort of a summary of the 8 or 9 sessions that I will be giving. So before I go on to talk about some more in-depth pathology in the cancer lectures that are going to be coming in future videos, it's worth going back to some ground that were covered in either pathological basis of disease or other modules, and what I want you to do is go back and find the definitions for these following terms and find an example where they are used. Now, deliberately set these up so that as we go from top, not necessarily the top one there, but from here down to here, we're heading towards, especially down to the bottom, heading towards pathological terms that are more associated with the development of cancer, whereas some of these terms up here are really nothing to do with cancer at all. But go and locate diseases that involve these terms, and then figure out or identify what is the definition of each of these terms given. So there's a whole bunch of other pathological terms. You hopefully have just researched what these are, because any of these terms could appear within an exam question without me defining what they are. So you will have covered atrophy, edema, inflammation, ischemia and infarction. That was all in pathological basis of disease, so again it's probably a good idea to become familiar with these basic terms that we've covered in previous modules. And then we're going to cover some more pathological terminology here, and I'll go through these particular ones in this video. I'm going to rely on you having looked back at all of these others. The reason why is the sort of question that I can ask is something like this: discuss the etiology or pathogenesis of some sort of dysplasia or hypertrophy. So I don't have to define these terms for you. I can ask a question using these terms and expect you to understand what these terms are. If you don't understand these terms, you won't understand the questions that I'm asking. And if I'm asking, the reason I'll be asking questions like that is if you're reading a scientific publication that talks about the etiology or pathogenesis of a cervical dysplasia, well, you need to know what those terms mean to understand what that scientific paper is about. So a little bit of work for you to do: look up these, and I'm going to go through these terms in this video. So these are the common basic terms that you must understand. You'll see these throughout scientific manuscripts. Etiology being related to cause, pathogenesis relating to how disease forms, but I'll go through these independently. Particularly morbidity and mortality, these get mixed up, and I'll explain how we plot mortality figures versus morbidity figures. Mortality is death. Morbidity, we often talk about disease-free survival as one of the measures of morbidity. So I'm going to go through each of these. Okay, first we'll deal with etiology. So whenever you see the word etiology, you're dealing with the cause of disease, and this can have many different diseases can have many different causes. So genetic aberrations, if you're looking at something like a genetic disease, cystic fibrosis, infective agents, HIV, COVID-19, chemicals, radiation, environmental. These are all could be put down as the cause of disease. So lots of diseases have a single cause. Other diseases have what we call a multifactorial etiology, multiple causes to that disease. So examples might be obesity, calorific intake, fat intake, exercise, genes, or a combination of all of those things. Those are all multifactorial causes of the disease. An interesting one here, and it's really worth following this paper here, is multiple sclerosis. Although I'm going to be predominantly talking about cancer in my part of the module, it's worth looking at this particular disease, and you've covered it in PBOD in the past, but it's interesting in that it has a clear genetic cause and it has a clear environmental cause, and it might have other causes as well. So if you have a quick follow on this paper, what you'll find is that some patients of some subtypes of this disease have a particular HLA type. You should know what that is. That is linked to vitamin D metabolizing genotype, and vitamin D is directly linked to sunlight. And what we're finding is that patients who live in a northern latitude with very little sun, so people who live in the Orkneys or Shetland Islands who don't exactly get an awful lot of sun, if they have a particular genotype that predisposes them to MS, they may well develop MS. If they have that same genotype but live in a far sunnier climate, South Africa, Australia, somewhere like that, those patients are very unlikely to develop MS because vitamin D metabolism is different depending on the amount of sunlight you get. So what we're looking at here is a multifactorial etiology involving genetics and an environmental effect. So sometimes the cause of disease can be many different compounding factors all combining together to cause the disease. Now, some diseases have no known cause, and we have a word for that. We term it idiopathic or spontaneous or primary. So idiopathic pulmonary hyperplasia and primary pulmonary hyperplasia, as far as primary pulmonary hypertension, they are two diseases, both of which with no current known cause. Now the one to watch out for here is that the word primary. Primary is used in a different context when we're dealing with cancers. So a primary cancer is the initial cancer that a patient develops at a particular site, let's say breast, and the secondary cancer is a cancer that has spread from that initial primary site to a distant site. So primary is used in two different ways, and you'll come across me talking about primary in lots of different ways. But when we're talking about cause of disease, primary, idiopathic, spontaneous all mean no specific known cause. Okay, so that's covered actual cause of disease. What we can now cover is causal associations, and these associations are typically markers for an increased disease risk, but not necessarily the direct cause of disease. So for example, we know that if you have a genetic alteration to apolipoprotein and you've got what's called the E4 allele, you're at a vastly increased rate of Alzheimer's disease. Now this doesn't cause Alzheimer's disease, it just means you are at an increased risk. And there are far more people with these E4 alleles that don't get Alzheimer's disease than do get Alzheimer's disease. So it's not an absolute clear-cut cause, but it's certainly associated with a risk factor. Also, one well-known case that you probably covered maybe earlier in this module, but the fact that in for infectious agents, causal associations are strongest for infectious agents, where you can see that infectious agent in a patient and you can see the disease. However, does that infectious agent actually cause a disease? And you will have been through experiments have to be done to prove that is the case, but one exception that you will have come across most likely is Kaposi's sarcoma. This is a tumour that develops in HIV patients, rarely found outside HIV patients, and for decades it was thought that HIV caused Kaposi's sarcoma, whereas in reality it's caused by human herpes virus 8, which is sometimes co-transmitted with HIV, but you only develop tumour formation if you're in the immune compromised state of HIV that the HIV patients experience. So this is an example where it appears that the infectious agent might on the surface cause the disease, but in reality it doesn't. It's sort of only, it's a different infectious agent to the one that you would obviously think is the cause. Now, to help disprove that HIV causes Kaposi's sarcoma, there are lots of patients who develop that in the absence of HIV, and they tend to be immunocompromised people, who suffer from either immune deficiencies or are immune compromised for things like transplant reasons and that type of thing. So that sort of adds further weight that HIV doesn't cause it, and it's now being proven beyond doubt that human herpes virus 8 is the cause of the Kaposi's sarcoma. And the next pathological term that is misinterpreted by a significant number of students is pathogenesis. And probably the best description of pathogenesis is the mechanism through which the etiology, the cause, operates to produce some sort of disease. And that can be multiple different things. And if you're looking at pathogenesis, you think, well, how can something like an infectious agent kill a person? And one of the key things is how that individual responds to that infectious agent. And inflammation is often key to this. So this link, which is on this previous slide that I've just shown, is a really interesting new paper that's just come out suggesting that patients who suffer from COVID-19, a significant proportion of them, 10 to 15% of them, are deficient of type 1 interferons, and some of those patients actually have autoantibodies effectively neutralizing their own interferons. So this is an example where one person will catch SARS-CoV-2 virus, which causes COVID-19, and will respond to it very favorably, whereas another person will catch that, and due to either an inbuilt genetic defect of interferon signaling or an acquired autoantibodies to interferon, to type 1 interferons, that can result in those patients resulting in life-threatening COVID-19, whereas everybody else manages to shake off the infection. So the way individuals respond to an infection is quite often very key to whether the infection is life-threatening or not. So that paper we've just looked at can be obtained by clicking on this link on the original PowerPoint version of the slides. So obviously the immune system is very desirable, but it can also be undesirable, and sometimes it is the immune response to a cause of disease that initiates the severe disease, and we know that COVID-19 is one of those examples. We also know that things like these allergies, there's generalized autoimmunity. So I mentioned multiple sclerosis, that's very much of an autoimmune disease where the immune system attacks the patient's own cells. So these are all linked in with pathogenesis. How does the cause mediate disease? Sometimes it is the immune system that is, shall we say, overreacting. The immune system's got to react to, let's say, COVID-19 or the SARS-CoV-2 virus, but in some cases that immune reaction is going on in a way that, shall we say, is not overly helpful. So whilst we're talking about pathogenesis, we can talk about other disease causing effects such as degeneration. So degeneration can be either long-term or short-term, sort of chronic or acute. And what we find is in some diseases like arthritis, it can be trauma-induced or it could be autoimmune induced. So arthritis, two main types, osteo and rheumatoid arthritis. Rheumatoid is very much autoimmune. Osteo can be deterioration, or it can be in a response to trauma. Sometimes that trauma, the immune system and general repair pathways are trying to sort out some sort of trauma, but then inducing osteoarthritis as a consequence of that repair not going particularly well. When we're looking at cancer and pathogenesis, we talk about carcinogenesis. So carcinogenesis is the process of turning a normal cell into a cancerous cell. So if you take something like benzoate pyrene, it's a tobacco smoke mutagen. It mutates the DNA within normal cells. It starts to make them behave badly, overgrow, stop undergoing cell death, that type of thing. And then eventually, with enough mutations, that can develop into cancer many, many years, even decades after stopping smoking. So carcinogenesis is the process by which DNA damaging agents accumulate to the point that the cell can no longer regulate its own normal cell growth and death. So we've got a few terms here that tend to get mixed up by students: latency and incubation period. An incubation period is the time from infection to symptoms of disease. So for COVID-19, a few days up to a maximum of 10, maybe even 14 days at an extreme, but mostly about 5 days. So that's your incubation period from being infected to having symptoms or signs of disease. In contrast, a latent period is the time from maybe initial insult, so in terms of lung cancer, cigarette consumption. What we can see is cigarette consumption goes up. A few decades later, lung cancer goes up. So this is a latent period. You start insulting, or creating the genetic insult to the lungs, and then a couple of decades later, the cancer develops. So that would be a classic latent period. And we see this also with hepatitis B infection. Hepatitis B, you catch the virus, you get symptoms within a few weeks. That would be sort of incubation period, whereas there's also a latent period where many, many years after infection and many years after you maybe think that the infection has resolved, you can then develop cirrhosis and liver failure many, many years after that initial infection has occurred. So one of them is incubation period, time from infection to some sort of disease, and with Hep B you will get viral type disease symptoms, whereas many, many years or possibly even decades later you can get this other phase of disease which is caused by an immune response to that infection, which we would class as a latent period. So the cause, which we're now going to call etiology, acts through some sort of pathogenic mechanism, which we're now going to call pathogenesis, to produce some sorts of clinical manifestations. This could be pain, it could be a lesion such as a tumour, or it could be just a biochemical change. So in many diseases they're often picked up by just a biochemical change, and then that biochemical change can sometimes be linked to the symptoms that the patient might be experiencing. Now what we can also have is initial disease, and then we can have complications of that same disease. So complications we call secondary effects of disease, or sequelae, and these secondary effects of disease are caused by the primary disease having another effect. So classic examples are primary tumours. Remember, primary tumours are the tumours at the site where they initially develop. They metastasize to distant sites, and we call these secondary tumours. Tumours may also have secondary effects on distant sites. So for example, myeloma kidney disease caused by this secretion of antibody light chains, which can cause kidney damage. So myeloma kidney disease would be classed as secondary disease to the initial disease, which is myeloma, for example. And there are lots of other examples of this. Cancer-induced bone disease or osteoporosis can result in fractures. The fractures are what we call, they are secondary to the initial disease. And again, not to be mixed up with secondary tumours. Other complications which may be more obvious: infections. So you could have an initial skin infection. That would be your initial infection, but complications of that could be when that spreads to a distant site. Obesity in itself as a disease could result in secondary hypertension or secondary type 2 diabetes. And then hypertension itself as a disease, whether it's idiopathic, no known cause, or otherwise, maybe obesity or something else, may then result in secondary cerebral hemorrhage as a secondary event to the initial disease. So you can have someone who's hypertensive for no apparent reason, idiopathic, and then maybe have cerebral hemorrhage as a secondary event to that primary disease. So when we're talking about disease, we're often talking about prognosis. Prognosis being how the forecast of the disease course. How is the patient going to do? Is the patient going to live? Is the patient going to die? Is the patient going to have symptoms? Is the patient going to be symptom-free? And you can describe prognosis in different ways which have sort of different meanings. I could say we have a population of breast cancer patients, 45 years old, they've got a 5-year survival. You might think, well, that prognosis doesn't sound overly good, but then if you said we've got a 90-year-old patient with breast cancer with a 5-year survival, you would say, well, that prognosis is actually quite good because they are more likely to die of something else rather than the breast cancer. So prognosis always has to have context of the patient group that you are dealing with. Now, a major part of understanding pathological data is being able to understand how this data is plotted in graphs. And I'm going to be showing you extensive Kaplan Meier survival curves, and these are used to predict likely disease progression and assess how a patient is likely to do compared to hundreds of previous people in the same situation. And we use these a lot in clinical trials. So we have one group of patients on a placebo, one on a drug, and we would hope that by following the proportion of people alive or dead, or symptomatic versus non-symptomatic, you will be able to then follow whether that treatment is working or not. So we call these Kaplan Meier curves. So this is a Kaplan Meier curve for a huge clinical trial. This is the clinical trial that resulted in some of the approvals for Herceptin, also known as trastuzumab. And these are basically measuring the effect of giving trastuzumab or not giving trastuzumab on some breast cancer patients. And we're going to be studying trastuzumab later on in the module. I know you've maybe covered it in a lab in the second year, but we're going to be looking at the tests that are used to determine whether patients get this drug or not throughout this module. Anyway, what these graphs are showing is one's showing disease-free survival and one's showing overall survival. So overall survival is a measure of overall survival from the start of the clinical trial, from day 1 through to 5 years. And as you can see, the curve goes down, and the curve goes down by equivalent of one person every time a patient dies. And we're looking at the trastuzumab arm versus the control arm. And what we can see is the control arm, that is no trastuzumab, the patients are dying slightly more frequently than the treatment arm, suggesting the treatment is doing something. There is a relatively small gap there of a few percent. So little difference in overall survival at 4 years, but there's a large difference in disease-free survival. And in this case, we're looking at disease-free survival being a disease progression. So the patients are given the Herceptin when they post-surgery appear to be disease-free, no sign of distant metastasis, and then we are measuring how quickly patients relapse from that trastuzumab therapy or their control. And what we can see is this goes down to 83% by 4 years, whereas the control arm is at 67%. So there's a much greater difference here than there is here. Only a few percent difference in overall survival, but of quite large difference in disease-free survival. And this drug is particularly useful at preventing rapid recurrence of disease. Now, one thing to be aware of here is these patients in the placebo or the control arm, they're not receiving nothing, they are receiving current best practice, which would be chemotherapy and other things, whereas the trastuzumab arm are receiving current best practice plus trastuzumab. So it's not that we're just leaving breast cancer patients here to have no therapy and inevitably die. They are receiving current best practice versus current best practice with additional therapy thrown in. Now, this is a valid clinical trial because, it's not that these are receiving knowingly receiving something inferior. Prior to the start of the trial, we didn't know whether the drug would make things better or worse. And in some clinical trials, you add in a new drug and the drug-treated arm does worse than the controls. So in that respect, it is a sort of, it's not a unethical thing to do. So those Kaplan Meier curves neatly lead on to mortality and morbidity. Mortality is the probability that the disease will result in death, and we can express that in multiple ways. For example, the 6-month survival of metastatic lung cancer is approximately 0%, whereas we know that the 4-year probability of death in the particular advanced breast cancer group that we were in the previous slide was 13.4%, decreasing to 8.6% with trastuzumab. So that's mortality. Morbidity is the effects of disease upon the patient, and this can be, depending on what disease we're dealing with, monitoring morbidity can be lots of different things, from pain and symptoms and fractures if it was something like osteoporosis. In cancer, it's often we use the standard model of disease recurrence. If the patients have had surgery and are disease-free, and then you get tumour recurrence, either at the initial site or a distant site, we'd call that disease recurrence-free survival. So if a patient is free from any signs of disease, they would be disease-free, and if they have signs of disease coming back, they would result in one of those Kaplan-Meier survival curves going down a little bit. So depending on what the disease is, the morbidity measure will differ, but you will often see overall survival and disease-free survival for lots of disease situations. Okay, so before we go on and show you more Kaplan-Meier survival curves, I'm just going to briefly cover epidemiology. And epidemiology is that branch of medicine that studies human diseases and their disease distributions, which generates data that can lead to clues about the etiology of disease. And this is a classic graph showing the frequency of different cancers in different populations. And so we've got Osaka 1970s, Osaka 1980s and 1990s, and then we've got the US population, Hawaiian, Japanese, Hawaiian Caucasian in different time periods. And what you can see is that the rates of cancer have changed within these populations, and where there's an identical environmental situation, such as Hawaiian, Japanese, Hawaiian, Caucasian, they're living in the same place, the rates of cancer, particularly breast cancer, are quite similar. So it seems to be that, so this seems to be controlling for a genetic effect, so an environmental, so potentially identifying an environmental effect, but excluding a genetic effect. So what we can see is, looking at Japan, the rates of breast cancer is very, very low, whereas people of a Japanese ancestry living in Hawaii have a very high rate of breast cancer. So that's what these graphs are showing, whereas the converse is true for stomach cancer. In men, prostate cancer is very, very rare in Japan, whereas in Hawaii, people with a Japanese ancestry, the rate of prostate cancer is not that different from Caucasians living in Hawaii. So epidemiology is the study of the disease in different populations, and that sometimes gives you a clue to the cause of disease. And this is just summarized here. So what we can do is look at the incidence of disease in lots of populations, follow it over time, see if there's any patterns that are changing, and then that can lead you to the potential cause of the disease. And the disease frequency can be expressed in lots of different ways. This is a rather clunky one, cumulative rate of getting that disease by the age of 75. So what we're saying is that in Hawaiian Caucasian men in late 1980s, by the time you get to 75, about 14% will have evidence of prostate cancer. So that's one way of expressing it, which is quite understandable. You can also have incidence or mortality per population per year. So, for example, ocular melanoma, a rare tumour type that I work on, the incidence is quoted as 0.7 cases per 100,000 people per year, which basically means in a city like Sheffield with about 500,000 people, there are 3 or 4 cases of this tumour per year within the Sheffield city region. So that would be classed as a very rare tumour. You could also express that as a cumulative rate by the age of 75. It's 60 in 100,000, which seems to be quite, but still nothing like this sort of level here, because 1,600,000 sounds quite high, but we're dealing with 0.06%, which would barely even register on this graph. So it is a very, very rare tumour. So this figure is the uveal melanoma incidence by the age of 75. This is the breast cancer and prostate cancer frequency. So you will see epidemiological data expressed in lots of different ways depending on what point is trying to be shown. So I'm going to move on to a couple more pathological terms that are really relevant to disease. That's remission and relapse. Now, some diseases will follow a short disease course. We'll call that acute. Others as chronic, and that's a more long drawn out disease course. And some diseases will have different periods of progression and relapse and remission. So these are 4 different groups of multiple sclerosis subtypes. Progressive, relapsing, multiple sclerosis. So this is where you get disease progression for a bit, then it will suddenly get worse, then it'll get a little bit better, but not as good as in terms of this is symptom severity as it was before, and then will progress at a steady rate, and then you'll get bouts of relapsing. In other cases, you will have something like primary progressive, where the symptoms just get steadily worse and worse. Or you could have something like this, which is relapsing and remitting, where you get relapse, you get remission, a period of stability, relapse, remission, and stability. So all of these different subtypes often have different, or likely to have different underlying causes. But these are the sort of pathological terminology that's used: relapsing, remitting, primary progressive, secondary progressive. So this is where you've got relapsing, remitting, and then progressive, much like this one, but you've got what we call secondary progressive. So all of these terms are routinely used, and you will come across them in other diseases as well. But the main thing you need to be aware of is remission and relapse. From a cancer point of view, you could say that a patient is in remission when their clinical symptoms have disappeared or their tumour is not detectable, and then they will relapse when that tumour reappears, or maybe all just have a biochemical relapse. A biochemical relapse would be the sudden detection of a tumour marker in blood, even in the absence of the detection of any tumour itself. Okay, so since we're on the theme of multiple sclerosis, this is probably the only time I'm going to talk about that particular disease in this lecture. We've got a couple of Kaplan Meier curves for multiple sclerosis showing different things. So in here we've got cumulative survival from 1, as in a fraction. So this is at the start of this study, or whatever the start of the study is, everybody is alive, and then through to the end of the study. Now what this is showing is cumulative survival from 1 to 0 as a fraction, whereas this is showing survival from onset in years. So what it's showing is, although at the end of the study everybody is, or virtually everybody has died, that is because this study is showing survival from onset. So it's a slightly unusual graph, but what it shows is that you can take all the multiple sclerosis patients from this particular study here, if you follow that link. I think this is a Canadian population, and you can follow this curve and ask the question, what is the 50% survival? So how many years from onset of symptoms or diagnosis would you expect 50% of patients to have died? And we often use the 50% survival as a sort of a routine rule of thumb to find out what is likely to happen to a population. So you could say 50% survival is about 50 years, which seems quite a long time, but then in many cases are diagnosed early. So that's illustrating one particular point. Now that doesn't hide the fact that some patients will die very soon after diagnosis, and some patients will die many decades after diagnosis. And this chart actually then illustrates cumulative survival from birth. So it's using this data to then extrapolate what is the likely age of death, irrespective of when you are diagnosed from this particular disease. And what I've added on there is this extra blue line, which is the curve for the general population, for this particular population. So you can see the expected shortening is this many years for women and this many years for men. So what you've got there is a few questions for you to have a go at. Look back at those graphs. I've sort of explained them, but you should be able to answer all of these questions based on those previous Kaplan Meier curves, because I can assure you that at some point in your assessment you will be assessing Kaplan Meier curves. So we can also look at different ways of plotting data, in this case plotting tumour responses in response to drugs, and in this case we're looking at maximum change from baseline, so that's at the start of drug therapy to the point where they were subsequently imaged, and for complicated reasons patients have been separated in this study to partial response, stable disease and progressive disease. Progressive disease, the clinical situation is getting worse. Stable disease, the clinical situation is stable, and partial response is certainly getting some improvement. And tumour size is only part of that. Tumour markers can also be part of that, so which is why there's some overlap here. However, that's not the important bit. All we're showing here is that in this clinical situation, KRAS mutants have been shown to be having more likely to have progressive disease and no partial responses, coupled in stable disease as being characterised by a whole range of scans and biochemical markers. Whereas if the patient's a wild type KRAS, you're more likely to have some partial responses, quite a few stable disease and fewer progressive diseases. And this is because the KRAS mutant, that is an oncogene that we're going to learn about in a few weeks' time. When that oncogene is mutated, it prevents the drug that is being given, panitumumab, from working. So panitumumab binds to some growth factor receptors, but if KRAS is mutant, as we'll find out in some later lectures, that renders that drug completely useless. Hence we've got this clear difference between mutant and wild types. So that's one way of expressing this type of data. The same data can be expressed in this way, where we've got our mutant KRAS, we've got survival probability, and we can see that these are very, very advanced cancers that have been treated here with an experimental therapy, but we've got progression-free survival and we've got overall survival. So progression-free survival is where we've got a patient who has got progression of their disease. It could be a new distant metastasis, it could be tumour growth, it could be a rapid increase in tumour markers. Various things could class that as being progression. This one is overall survival. And what you can see is you initially get a rapid, in the KRAS mutant group, a rapid dropping off in progression-free survival, and then that later that will translate into changes in overall survival as well. What we normally see, what we see in this situation is that the KRAS mutant are undergoing both progression-free survival and decreases in overall survival quicker than the wild type, suggesting that the mutant KRAS group have a poorer prognosis. So that's what we're trying to illustrate here. Understanding these graphs, in blue, your mutant KRAS have a poorer prognosis than the wild type KRASs in this particular therapeutic situation. Okay, so we've covered quite a lot of stuff here. What I want you to do is find the definition for these terms. I've mentioned most of them, but just be clear that you understand exactly what these terms mean and you don't mix up similar terms like morbidity, mortality, remission and relapse. So find definitions for all of these terms, and you certainly must be able to define the early terms I've just been through in the lecture, and you need to appreciate the methods used to quantify mortality and morbidity, understand disease-free versus overall survival, and be able to interpret Kaplan Meier survival curves, because I can assure you I will be interrogating you at some point on this type of data. Okay, I think that's probably enough for this lecture. On the original PowerPoint there are a couple of other bonus slides if you want to have a little look at those as well.